Okay, sharing again. All right. Hi, everybody. Sorry for technical difficulties, just kind of getting used to the whole Zoom thing. I think we're all much more used to WebEx and that kind of thing. Anyway, welcome to Preceptor Development. And the title here is Residency Quality Project Reboot. So it's time for ideas. It's time to get excited about quality projects and bringing those ideas forward. I think we have all recognized for several years now our wonderful research program, our research committee has done such a wonderful job with these projects, but they just don't have the bandwidth to continue doing quality and research. So Amy and I have volunteered to coordinate the research or the quality projects and take that off the plate of the research group. So with that, that also gives us an opportunity to kind of reset our mindset around how these projects are done and how we want to structure them a little bit. So just a little background of the interest in quality that Amy and I have. Several years ago, Amy had the opportunity to go to the ASCO Quality Training Program, and the American Society of Clinical Oncology had put together an entire program specifically designed for busy clinicians, clinicians who have problems they need to solve, but they need to do it in the concept and the construct of their busy lives taking care of patients. And Amy has gone through this program and she has presented her work to Cancer Center leadership, to the quality program here at UVA. Jeremy Sen has been through it. Last year, we put our resident Meredith Mort through it. I am currently going through it, although we are paused for COVID. And our PGY2 Corey is also participating in this with me as well. So we have a soft spot in our hearts for quality, and we really wanted to share that with all of you. And some of you may be wondering, how is this different from Be Safe and the quality initiatives that we've already been working with? And the reality is, it's all the same thing. It's all lean methodology. It's all taking a look at processes. I think what Amy and I find striking is, I guess because we're oncology people, and ASCO has really done a good job at making these tools relevant to what we do. So I'm hoping we can share some of that with you. What we want to do today is get you thinking about, as preceptors, what kind of quality project ideas do you want to bring forward? So I'm going to kick us off by just talking about some background, and then Amy's going to pick it up and give you some examples of some of the projects that we have done through our team and through our multidisciplinary teams, and give an overall introduction to some of the tools that we're going to be focusing on with the residents. And hopefully by the end of this, you'll be thinking, you know what? Coming up with quality project ideas is pretty straightforward. It's not as overwhelming as maybe we've made it before. So hopefully we'll all come away from this having some ideas. So the first thing I want to talk about is kind of resetting your mind frame for this. I think as pharmacists, we're very, very focused on research-based projects. And so to shift from research to quality improvement, if you look here at this table, with a research focus, we're thinking about a hypothesis and testing a hypothesis, and we're focusing on clinical outcomes, and the outcomes are really the most important thing to focus on. With quality improvement, a lot of times we don't even know what the problem is. We just know something's wrong and it manifests itself in what we're observing. And so part of the quality project is identifying what the problem is. We need to look at our existing processes, including the flaws, and then take a deep dive, and we're going to come up with an aim statement. And we might not be able to come up with our aim statement, and if we sort of equate that to the hypothesis, we may not be able to do that until we really take a look at the data and understand the process and what the problem is. And our focus for quality improvement is really looking at the process, because we all know we can have the best clinical plan for our patient, but if our process doesn't allow us to deliver that clinical care to our patients, we're going to fall short. So what is quality improvement? Well, right, this is it. There's a problem, there's a solution. No, 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 no. And I think even our basic introduction to our Be Safe program has made this abundantly clear. Don't jump to solution. And don't come to a quality meeting thinking you know what the problem is and you know what the solution is. We really want to focus on the process. And in order to do that, we need to pull some data. The data, you know, we focus a lot on data, and you're going to see a lot of examples of the kind of data we're going to look at when Amy takes over. But it's interesting, through the ASCO program, there's a quote they use to describe how important data is, and it's a quote from JFK. And he says, "For the great enemy of truth is not the lie, which is deliberate, contrived, and dishonest, but the myth. The myth is persistent, persuasive, and unrealistic." And I think oftentimes we come into a problem thinking, oh, well, obviously the problem is Dr. Jones can't write his prescriptions on time. But when you start peeling back the layers, you realize, oh, it probably doesn't have anything to do with Mr. Jones writing prescriptions. It has to do with all these other things. So really focusing on the data allows us the opportunity to objectively look at something without introducing our own assumptions or our own personal bias. So where are we going to come up with all these fabulous quality project ideas? We're going to come up with them from things in our everyday practice that cause us angst. Think about processes that have unwarranted variation. Now, before people start throwing things at me or raising their hand in the chat saying, oh God, we're not talking about standard work for everything, are we? No, we all know that many of our processes have variation. It's life, especially a clinical process, because there's variation because of our patients, their comorbidities, patients' wishes, all of those things. However, there are sources of unwarranted variation. So think about processes where you see variation that cannot be explained by scientific evidence or by patient preference. What are those things that we really shouldn't have variation because it's interfering with our ability to deliver patient care? Think about Be Safe events. What are those things that something went wrong, whether it was care coordination or something went wrong, we had a near miss, maybe an error did hit a patient, and it's a process issue. Think about Be Safe events. And I love this. Amy came up with this. Just what are those things that bug you every day? You know, what are the things that you know there's a problem, but you can't quite figure out what it is? I know when I was trying to come up with a project for ASCO this year, Amy said, you know, Kathy, sometimes the best projects are the things that you don't know what's wrong. So you don't have to know what's wrong. It might actually be better if you don't know what's wrong to come up with an idea. So we also have to think of scope, right? Because our residents have 6 months to do this. Our PGY1s, at least as of now, we still want them to present a poster in December. So we need to think about that. So this just kind of gives you an idea of the scope. So some of these things are really small, and maybe they're not going to make a good quality project. It's something where, you know, there's not many people involved. You kind of think you really do know what's wrong, and if you just fix a form or a dot phrase, it'll work. And it's sort of the just try it. What's the risk if you just try it? Okay, we fixed the problem. Then there's these really big projects like World Peace or MedRec that are gigantic, and you'll never get your arms around it, and they really take organizational level strategic planning. We're looking for somewhere in the middle. What are some of those things that are medium scale? They can take weeks to months to fix. You can have a varying degree of personnel involved in it, and your risk of failure, you know, what happens if you get it wrong? Well, you try again, you know, low to moderate risk. But the potential value for all of these things are high. So we're trying to find this sweet spot for a quality initiative. One of the things that we want to focus on with our residents is this model for improvement known as the PDSA cycle, or the Plan, Do, Study, Act. Now, this is not a unique concept to ASCO or anything else. You're going to find various iterations of this in the literature. And I think the study part has a lot of different acronyms depending on who's putting forward the model. So this is not new. And I'm sure many of us are doing this with our UBLs, any Be Safe initiatives you're working on. And so this as though has become the vernacular that Amy and I use just from the ASCO program. And you'll notice a lot of our slides are borrowed. So I do want to give a shout out to ASCO for helping us with these ideas. But the PDSA cycle, and it's important to think of it as a cycle. This is about ongoing process improvement, not just a one and done. But we want to come up with a plan, and we're going to give our residents the tools to do this. We do want our residents to actually implement something, a change. And then we're going to test that change. A lot of our Be Safe methodology is what's the test of change? So we're going to have them do that. And then we want them to measure that change and see if they met their aim statement. And as long as they can then assess that, that's at least one PDSA cycle, which should be enough to get a poster out or whatever. But it doesn't mean it has to end there. It could go on for a little more when you report out to your quality improvement group, and it might be something that the clinical pharmacist can continue on. So this is the model that we want to implement. So how do we make sure that it's a project that can be done in the residency year? Let me take a step back and talk about variance again. We know that with every process, there is normal variance. And you always have outliers. That's sort of the abnormal variance. So you want to think about whatever your problem is or whatever this thing is that bugs you. You need to have enough data points or enough events. They have to happen with enough frequency that you can measure your test of change in a reasonable time frame. So one of the questions when we talk about the new quality project form is how often does this thing that bug you happen? Does it happen once a day, once a week, once a month? And we want to make sure that it happens with enough frequency that we can have some baseline data, implement your change, and measure the change. And you probably need 7 or 8 events within your cycle so that you can get rid of some outliers and make sure that you're testing the change of your actual process and not just bringing outliers into the fold. So we think that once you implement your change and you test that change, if you have a good 1 to 2 month segment of time to test your change, you should be able to get through an entire PDSA cycle. And I think within 6 months, that's a reasonable time frame. So that was the background that I'm going to share with you. I'm going to stop sharing my screen and we're going to switch over to Amy. And she's going to pick it up from here and give you some examples of some projects that we have done with our HemOnc team in an interdisciplinary fashion, and some projects that have gone through the quality training program that will help give you an idea of how some of these tools can help our residents and help us. So Amy, are you ready?
Yep, can you guys see that? Well,
and if you come up with a question as we go, feel free to stick it in the chat and then we can read them at the end if that's helpful.
Yeah, so we wanted to give a couple examples of the projects that we've taken through, just maybe that would help some of these things make a little bit more sense, or it might spark an idea. And apologies, because they're both the projects that we're presenting are obviously oncology related, but hopefully they can make sense for a wider service line. So this was a project that Jeremy actually did several years ago. Essentially, we knew patients with scheduled admissions to the hospital, so planned chemotherapy, were often delayed, meaning we knew what they were supposed to be getting. They were on a pre-admission calendar. They would get admitted, and then we would come in the next day and their chemotherapy hadn't started. So obviously, this is very problematic for multiple reasons. Patients are upset, healthcare resources are wasted, and the problem really was that we didn't know what the problem was. Like, why was this happening? Why were people getting delayed? Was it because the pharmacy wasn't making it in time? Was the orders aren't signed? Did they have a paper consent that got lost in the chart, not get labs? There were so many different factors that were potentially contributing, and may or may not be contributing to all or some of the patients. And so we really had no data on this going into the project. Jeremy did a little bit of baseline data collection. And again, for the purposes of the resident quality project, this would not need to be done ahead of time. You would just need to know that like something wasn't working right or efficiently. So when Jeremy did initial data collection, it showed that the average delay in start to chemotherapy was 12.1 hours. Clearly not ideal. So his team did a lot of the tools that I'll talk about next, and they ended up doing 2 PDSA change cycles. The first thing that they did, they updated the chemotherapy consent, which had been a paper form. And then the second change, they actually decided to have the hem-onc pharmacist the day before admission review the Beacon chemotherapy order, look for any things that needed to be clarified, signed orders, etc. All sorts of issues can happen in those. And so once they did these 2 process changes, which was over about a 6-month period, their delay decreased to 9.4 hours. So not perfect by any means, right? I mean, ideally the patient would hit the room and chemo will be ready to go. But I think one of the things that I just want to emphasize is that even no change in the delay would still be a good thing, because you're going through the process, you're identifying steps that potentially aren't working well. And for the purposes of a resident project, they're learning all of these tools. So even if the average delay had only decreased to 12 hours, we would still consider it a successful project. The second project was actually one that I did a couple of years ago. And I want to highlight also that, the names that you see at the bottom here, it's me, it was one of our oncology fellows, and then one of our 8 West nurses. So it's really important that these teams be multidisciplinary so you can get everyone's perspective. It's really important to understand frontline staff perspective from all angles, not just pharmacy. So I think it lends well to a great resident project, because they're going to be able to meet and closely work with hopefully a lot of members of the interdisciplinary team in whatever area they choose. Our problem was that I had actually done a resident research project looking at something slightly unrelated, and discovered that we had a very high rate of IFI in heme malignancy patients. But again, we didn't really understand. We just had this one data point. We didn't know what patient population was most affected, when in therapy, were they getting antifungal prophylaxis, what were they getting, was the ID actually involved upfront? So lots of questions that needed to be answered to appropriately address the situation. Our initial data, which I had from that previous resident project. So again, if you have an idea and you have some sort of initial data to throw in, that's great, but it's not required. So we had a 21% rate of IFI in our AML induction patients. We did 2 changes during my time going through this ASCO program. The first one was we instituted fluconazole prophylaxis in some patients. And then the second change, which was actually more robust because we had an ID physician and pharmacist on the team as well, we created a whole set of guidelines, including mandatory ID consults for patients with fevers. And at the time that we published this, our rate actually went down to 0. So I think it's a great example of how a process issue, i.e. patients not getting consistent care or not having a guideline written, was really affecting clinical outcome. So kind of think about those types of ideas as well when you're formulating a project. Certainly you can have something that doesn't really have a huge clinical impact, but this is also another way to kind of think of ideas. I've nerded out a lot. I really love the ASCO quality group that runs this, and one of their nurses, who is like a 50+ year nursing history, she's done quality at MD Anderson and Vanderbilt. She loves to put these really long quotes on slides and have people read them to themselves silently. So I thought that would be fun. But I do love this quote, and I really like that it talks about reflecting on how we practice and thinking about how we can get better outcomes through this type of tool. And, you know, I think we all realize we're kind of in a strange situation now, especially financially, where we don't know how long this is going to go on. And I think we're going to be asked by the administration to really find ways that we can help improve quality, but also keep our costs low. So perhaps there are some ideas there for our resident projects next year as, you know, we continue to figure out where we're going to be in a couple of months with this COVID situation. So next part of the presentation, we're going to very briefly go over some of these tools. I just wanted to show people the kind of tools that can be used for these projects, and to also talk about how, you know, in a research project, you're really trying to get the resident to get all of that data collected so they can have a result on their poster and they can have a discussion and conclusion. You know, with quality, it's almost easier to make a completed poster because you don't necessarily have to have the complete result of your change cycle. You could have all of these other inputs for your poster that are almost as interesting as the result of your change cycle. So that's something that I think is nice for the time frame of the quality project, you know, needing to be done a little bit earlier in the year. If they can really meet with their team and get through a lot of these early steps, they have a lot to present on, even if they haven't quite finished whatever improvement they've decided to do. So the first one I'll talk about is a problem statement. So the problem statement is describing your problem quantifiably using the 5 W's. So what's happening, who is affected, where is this occurring, when, and then why is this a problem for patient care? And the why, I think, is the hardest part of creating this problem statement, because our inclination is always to fix, to solve. I mean, that's what we're trained to do, but you don't want to do that in your problem statement because you don't want to make assumptions about what the solution is. So down here we have be specific, but don't describe how. You can see in the next example. And I absolutely have ripped off Jeremy's article from a couple of years ago and used all of his examples because it was a fantastic project that they did, reducing time to chemotherapy. And so hopefully that will highlight some of these tools and make them make a little bit more sense. Oh no, I didn't include Jeremy's problem statement. Oh shoot. Well, I can send that out after, but it's a good example of it. So they created their problem statement, sorry about that. And then after that, they want to create this aim statement to pick a goal of your improvement effort. It needs to be a SMART goal or SMART aim statement. You know, we've all learned about that. So this was Jeremy's team's aim statement. You can see below. It's very specific. It's obviously relevant. They had a time bound, so by January 2017. And then measurable is really the most important thing to have in here. You need to be able to measure the effect of your change. Otherwise, you don't know if what you did made a difference at all, or even sometimes makes things worse. Another tool that is essential to use in QI is process mapping. And so this is sitting down with your team, preferably frontline staff that are doing this work, and diagramming the current process. Not what you want to happen or not what's supposed to happen, but what is actually happening right now. And so you really have to understand the current workflow before you try to make any sort of change. And what's so funny about this is that every time I've sat down to do this with a group, whether I'm a team member or a coach, there are always people that are like, wait, what? That's happening or not happening? Or how does that work? And it's so funny that something that you think is very simplistic ends up being this crazy process map. This is the time to chemotherapy process map for an attending deciding to admit a patient for chemo, which is all the way up in the top left, and then all the way at the bottom right, start chemo. So now we can start to understand why patients are delayed and why it's so confusing to figure out what to fix. And in their process map, because Jeremy is so thorough, they have their different value add colors here. So a lot of red waste that they needed to work on. The next step teams typically do is something called cause and effect analysis, or Fishbone. And so that's a way to brainstorm with your group to identify possible causes of the problem and to try to sort those ideas out into categories. I think it's very interesting how ASCO recommends that people do this work, given that a lot of their interdisciplinary teams have a lot of attending physicians on them. What they actually ask teams to do is they provide everybody Post-it notes, the same color Sharpie, and they tell people in silence for 5 minutes, write down all the causes that you think of a problem. And the reason they do this is because they found that if people are shouting out answers or supposed to verbally make recommendations, a lot of times the attendings tend to shout everybody down, and then the nurse who actually knows what the problem is and knows what's going on doesn't actually say what it is. So I think this is a really great tool, even if you have a team that works very well together. So the outcome of your cause and effect brainstorm would be something like this. I mean, again, they had a very, very complicated process with a lot of problems. But you can see all the way on the right, that is your outcome. So starting the chemo, and all of these different categories like inpatient pharmacy, inpatient hemonc unit, nursing, administrative issues, all of these were possible causes of the problem that they were able to group. And so that also can be really helpful to identify any breakdowns in the process and what is actually going on. The next tool that is helpful in a lot of projects, not all projects, but a lot, is the Pareto Chart, which is also called the 80-20 rule. I don't know if some of you have heard of this, but what it does is it helps you prioritize the most frequent causes of a problem. The man who created this concept said that 80% of the effects come from 20% of the causes. You can see in Jeremy's presentation here, it's a little bit complicated, but I learned well from Heather. So let me show you this graph. So on the left, you see the y-axis is the time between the previous and current events. So they were measuring the time between each one of these steps that had to happen before chemotherapy could start. You see on your X, pre-medication, IV fluids, the chemo order assigned. And what they've done is they have gone through the data set for a specified number of patients, and they've looked to see how long is it taking for each one of these steps to take. So this is some of their baseline data to see what is actually happening right now. And as you can see, the way that they have prioritized these things is like a histogram. So they're seeing that the most time that is being taken up is for pre-medications and for IV fluids to start. If you see the dotted line across, the green dotted line, that's 80%. So 80% of the effects come from 20% of causes. So what this does is it helps you prioritize what things are causing the most problems and what you should probably try to start focusing on. Because if you go all the way over to the right and it looks like maybe a very small amount of time was spent waiting for a lab order to result, or I guess a lab order to be done, it really doesn't make sense to focus on changing that part of the process because you're not going to see much effect from that overall. Another tool is a priority matrix. I find this really helpful because it can start to get overwhelming thinking like there's so many different things that we could do. How do we decide what to change or focus on first? So the team comes up again, brainstorming with potential interventions based off of that Pareto chart, or there's a couple other tools that you can use if the Pareto doesn't apply to your problem. And so what you do is you take all of those interventions and you put them on this matrix. So on the y-axis, you have impact, so low to high impact, impact of the change, that is. And then on the x-axis, you have ease of implementation. So something that's really easy is over on the left versus very, very difficult on the right. And what we like to do, especially in these shorter, couple weeks to months long projects, we want to focus on this quadrant. You want things to be high impact on the process, but fairly easy to implement. If you look all the way over to the top right corner, add more nurses, add more rooms, 24 hours chemo pharmacists. Yes, would be great. Never going to happen. So you got to kind of move over to the left a little bit and see, like, what can we actually do right now? And you can see on here that pharmacists reviewing and fixing the plan was one of their interventions that they actually ended up doing during this process. And then right below the red bar, you can see remove chemo paper consent, which actually had more of an impact, I think, than they thought. But it was something that was kind of already starting to change, if I remember, Kathy. So that was something that they just decided to go ahead and do to get that into Epic. Okay, this is my favorite slide. I'm really going to nerd out here. So these statistical process control charts are just the bread and butter of quality improvement. They are the way that you measure your change over time to determine if what you've done as an intervention is effective on the process. I think it's really important in QI to remember that you've got to follow up the change. And I think that we've all been a part of projects that you do something, you spend a ton of time doing an intervention or something like that, you don't ever actually see the follow-up, and you don't know if it actually worked or made things better. And again, what ASCO leadership will say a lot in the projects is, like, a lot of these things actually make things worse, and then you have to fix them again. And that's fine as long as you're moving forward and you're measuring it, because if you don't measure it, you have no idea what's going on. So these charts look very complicated to create. They really are not. And what is great about it is that we've been able to present these types of charts to oncology leadership and have really seen good results getting, their buy-in, because I guess I could show the example so you could see, but it's really easy to read. And so I think these are great tools for the residents to have, and for you all to have, frankly, if you are trying to change a process or work towards something. I think these really speak to leadership and others who might not be directly in your practice area, but can understand these sorts of things. So with the time to chemotherapy project, you can see the hours here of delay or time to start are on your Y, and then each blue dot is a patient, so patient encounter. They did theirs chronologically to see, sometimes, there's variation in time of year or month or time of day, depending on your project. And so here they've got their baseline data. And this actually was like a slightly different spin on the project that they did later. So you'll see their mean is different, but I like this chart, so I wanted to show it. So they've got their mean of 6.3 hours as their purple line. And then after they do their cycle changes, so in this project, their PDSA1, their mean actually increased, which is very interesting. They weren't sure if that was actually significant. Again, you don't have to necessarily get into statistical significance here. So that was one of their changes. And then you can see in their second PDSA cycle, which has more patients, their mean dropped to 5.8 hours. But I think it's just a great way to show your change over time. You can see your variation. You can see control limits on here, which I think, in research, we're kind of trained not to look at those outliers, but in quality, it's actually really helpful to look at them, because they may be harbingers of other things. It may be actually helpful to look at a patient who potentially was a delay of 47 hours. What happened there? Like, what could we have done differently for that patient? Because every point on here is a patient. So that's one of the tools that I would love for the residents to be able to use and take away from this type of work. I'll let Kathy talk about this a little bit, because we were talking about the research form, the application, and we wanted the quality form to reflect more of these types of quality questions. And so people didn't feel like they needed to gather as much information ahead of time. Kathy, do you want to talk about the form a little bit?
Yeah, so I think one of the things that we recognized is the previous quality form was really an adaptation of the research form. And so a lot of it followed. And I had people say to me and to others, you know, it's kind of hard I have this idea, but it's kind of hard to make it work with the form. So if you look here, and of course, the top of the form will still have, you know, who are the project coordinators and blah, 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 and which programs is it for. But we want people to start thinking about a quality project rather than a research project. So these are all the W's that Amy showed you for the problem statement. So just getting you to start think about what's happening. What is the event that we're observing that's making us crazy? Who is affected by this? And the who actually on this is supposed to be what patients are being affected, or thinking about the patient. But it was interesting. We asked Andy to try this form to see if it helped him with his thoughts. And it was interesting. Who is affected by the problem? He actually listed not just patients, but end users that were affected. And it really helped him think through who all he needed to put on the team, you know, for this kind of a project. Where is it occurring? That helps you narrow down units, or helps you kind of narrow down things like that. When is it happening? What's your time frame? And then why is it a problem for patient care? Of course, sometimes as you're answering these questions, it doesn't indicate to anyone, well, there's probably more to the story. So sometimes if there's relevant background information, you know, oh, it drives us crazy. You know, we spend all this time putting together an admission calendar to 8 West, and then all of a sudden one patient's bumped and another, and it's a waste of resources. This gives you sort of a little more of a paragraph form to identify what's the problem. And then is there any relevant literature on this problem? Have other groups looked to do something about it? Or maybe it's even just literature that defines why it's a problem or why it's important for patient care. And then here's what we were talking about. How frequently does this event occur? Daily, weekly, or monthly? And if the event occurs less than once per week, maybe this wouldn't make the best project for a resident to complete in the time frame. Maybe it would, you know, maybe you get clusters of them. I don't know, but asking you to think about defining that will help us figure out if we think it makes a reasonable project for a resident to legitimately complete in the residency year. So this is a draft right now. Obviously, Amy and I are going to take some of this stuff back to Rock and brainstorm a little more with our program directors and things like that. So that's the draft of the quality form. I guess the one thing I do want to make sure we're not scaring anybody with this presentation. We wanted to give you an overview kind of how we saw this evolving. From you as the primary preceptors of these projects, right now, all we want you to do is think about what kind of projects are out there. What are the things that are bugging you? Where do you see variance? What is causing these safe events? What are those things that just frustrate you every day that you wish could be better? And start asking yourselves these questions. How many times is it a problem? And is it something that we think we could formulate into a quality project? I also want to make sure we're very clear that Amy and I are not going to precept all of these projects. I think we recognize that having residents work in pairs, at least for the PGY1 program, works very well. I think what we would like to do is help people formulate ideas for these quality projects. We're very happy to vet these and ask some questions to make sure we've got projects that can be done. And we're really happy to help coach through some of these projects. One thing I didn't mention in my introduction to all of this is that Amy has the privilege of, she was asked to train to be a coach for ASCO. So she's got some real experience, and I'd love to tap into that experience. I'd love to tap into Jeremy's experience of doing these projects. And of course, I'm gaining this. So I think we can certainly help guide people in the right direction. We plan on doing some overview sessions at the beginning of the residency year about some of these techniques. with our residents, and we would certainly encourage any preceptor or preceptor pairs to come to those and learn. And we can certainly help guide you and help you figure out what tools might be the best to use. But there is really very little risk that if you don't apply a tool exactly how it was intended in the literature, that's not going to make or break your project. The most important thing is that you develop the right team, you brainstorm together, and you work through this process. It's not about applying each tool to the letter of the person who developed it. It's really about getting groups of people together, frontline staff that does the work, getting buy-in from service lines and things, and working the process and showing, okay, we brainstormed these potential problems, we decided to implement this potential solution, and then we're going to measure the change. Did we make it better? Did we make it worse? Did it not change? There's lessons to learn in all of that. And then hopefully there's time for another cycle and we can implement something else. And all of us can learn together about how we can, step by step, improve processes that make our patient care EVA better. So that's our plan. What are your thoughts? Does anybody have an idea? First of all, does anyone have any questions about this? We will make sure that we send out the official quality proposal form once we've gone through our due diligence to make sure we have a draft and the ROC is comfortable with it. And then we'll set a deadline and we'll ask for your ideas. So we're happy to entertain questions. And also, if anybody has an idea, you're just sitting there saying, oh, I got this idea. I wonder if it would fit. Bring it forward and let's brainstorm together to see if we can figure out if it's a good idea. Chances are, if it bugs you, it's a good idea. If it's process related, it's a good idea. And if you don't want to raise your hand or unmute yourself, you can send it in the chat. And I don't have to read your name.
Can you raise your hand on here? How do I do that?
I think you can. I don't remember how. Yeah. Or maybe you can't. There's one of these that you can, virtually raise your hand or whatever.
If you hit participants, then you can raise your hand.
Aha. Does this make sense? Does this seem like something that we can do? I think we can do it, and I know Amy thinks we can do it. What do you guys think?
Andy gave a thumbs up. That's nice.
Yay! And thank you, Andy, for being our guinea pig. And we have thank you guys for preparing this. It seems very doable. Okay. And again, we want to guide you through this. And I think the more our teams are using some of these tools, this pharmacy department is going to be a force to reconcile with. I mean, we're going to be solving problems all over the place. Love this. Thank you for all your guidance. Okay, so we're getting positive. Any concerns? Anything that worries people?
This is Heather. I certainly don't have any concerns. I just want to say thank you so much for doing this. This is excellent. And these are the types of strategies we're seeing from medical center leadership as well. So I think, dovetailing with what they're used to seeing will potentially elevate the results of our projects. And anyway, I just really appreciate you guys doing this. And I think this takes us in a great direction moving forward. So thank you.
Thanks, Heather.
Thank you for that.
There are lots of opportunities right now to publish things like this that are quality based. Essentially what Heather is saying, like this is becoming a real initiative for most medical centers around the country, if not the world, because we're just realizing, we're throwing more and more money and resources at problems and they're not actually getting any better. So I think, for our residents, CV and all of ours, I mean, these are great things that you can easily get published and presented.
All right, well, we're happy to stay on for a few more minutes. If there's no further questions or anything, we'll give you some time back in your day.
Thanks,
All right,
everybody,
well,
for
thank
listening.
you, everyone.
Hope to see your face soon.
Yeah, in person.
Mhm.